All right. So, first, I'd like to welcome everyone to our first diversity dialogue session or discussion of the semester. For this discussion, it will be a little different than how we traditionally do things. We are joined by our wonderful ECU panelists to discuss what has disrupted and changed all of our lives over the past 7 months, COVID-19 or the coronavirus. The novel coronavirus, which began in China in December 2019, and then the first tested case in the United States being January 21st in the state of Washington. Since its arrival, we've seen an uptick in xenophobia against Asian and Asian American individuals. We have also seen that with this disease and the response from the health community has further highlighted the disparities that exist within the healthcare for our communities of color. Within this hour panel discussion, we will talk about some of the issues that have arisen and gain perspectives of those who work in the field. I'd like to introduce our panelists. We have Dr. Cedric Wright, who is the Associate Dean for Admissions at Brody School of Medicine. We have Dr. Susan Pierce, the Associate Professor of Sociology. Dr. Marla Hall, an Associate Professor in the Department of Public Health. And Dr. Ronnie Bell, a Professor in the Department of Public Health. So we're going to get started. So I am going to start with Dr. Bell. Would you consider race and ethnicity data collection and reporting to be critical information during the pandemic?
Yes, can you hear me okay?
Yes.
Okay, great. Yeah, so absolutely. And I think this is an issue. I actually serve on a statewide panel or a statewide committee looking at these issues. I think without having accurate data to look at, we really can't know the extent of the issue and how it's affecting our racial and ethnic minority populations in our state and in our country. This has been an issue that has been identified because there's not a mandate on recording race and ethnicity on those documents that are used to identify cases. And even to some extent, there's missing data on hospitalizations and death certificates. So it puts us at a real disadvantage in trying to understand the extent. Now, obviously, the data that we do have available to us shows huge disparities. I think the most recent data that we've seen is Blacks and Latinx populations are up to 3 times more likely to be diagnosed and more than twice as likely to die once they are hospitalized. So, but again, we don't know the full extent of that because the data is just not available to us.
Okay. Dr. Wright, you're muted if you're wanting to jump in on that.
Too many mouses to work
There you
with
go.
over here.
I got you.
What I want to add on to that, Dr. Bell, this is not new. This has been an issue for all the time that we have been looking at disease processes in America. That we have not collected the type of data that we need in order to know, to be able to drill down in real time, much less even retrospectively to understand how our communities of color are being impacted. And then there's the other aspect of that is how do you determine, how is that race being determined? Is it being self-reported versus phenotypically reported? And those incidents, in fact, oftentimes people will say that your health outcome is related to how you are phenotypically cast, as opposed to what you may identify for yourself. So from that, just from that kind of visual perspective, can also impact people's health outcomes, whether they define themselves as a category or not.
Okay. Dr. Pierce, how would you say that impacts within sociology the fact of communities of color trusting medical professionals?
All right. Yes, thank you for having this panel. There's definitely a history, and I think my colleagues know about this, a history of mistrust, especially by the African American community, of medical sort of medical universities as well as hospitals, right? And there's a real reason for that, right? You all probably know about the case of Henrietta Lacks, whose cells were taken without her family's knowledge and used for research all over the world. And there's also been documented cases of Black cemeteries being raided for medical for cadavers for research. So that is something that then has fueled a lot of concern and other things as well, such as the Tuskegee syphilis experiments, has fueled a lot of distrust and maybe conspiracy theories, right, for better or for worse. And so, who do you trust? And is there some hidden motive there, right, that the communities of colors want to know about and feel like, that this might not be in their best interest to, to get too close to the medical community.
Sticking with you, Dr. Pierce, why do you think that some of the issues around the xenophobia with our Asian American communities have arisen at the start of this, the othering of our communities?
Good question. This is not new. As you probably know, historically, even go back to 1900, there was a Chinese man who died of the plague in San Francisco. And so the entire Chinese community was forced to quarantine, but others were able to go as they please. So there's been a history of blaming diseases on particular ethnic communities. And in this case, of course, from what we know, it may have come from China, although I'm not sure that's been fully determined, right? I've also heard some possibilities that Europe might have been the start of this. But in any case, the fact that there was so much publicity to this Wuhan province, right, and to this meat market, and then a conspiracy theory that it was in a lab in Wuhan, then the fact that it got named informally the Wuhan flu or Chinese virus or whatever, and even after the WHO renamed it COVID, because they have started not naming diseases after their locations for these exact same reasons, right? That people get stigmatized. But that informally, people still continued to call it that, right? Call it the Chinese virus. So what happens is not only Chinese immigrants, people of Chinese descent, getting somehow blamed for this, but also it gets generalized, right, to an Asian other, because people see the phenotype of the Asian. They don't know if they're from Vietnam or Indonesia or wherever, but they still are getting basically racist attacks as if they're the ones who are carrying the virus and spreading it and infecting everyone else. So there's definitely this history of kind of xenophobia, anti-immigrant sentiment that's related to carrying diseases that we're seeing, obviously, an outbreak of now. It could be that some of that's died down recently. I was looking through news reports, and it seems like most of these were being reported in March and April. So it could be those have died down. I wouldn't say that they've stopped, though. So.
Okay, thank you. Dr. Hall, would you be able to maybe address why, even after controlling factors such as age, has the data shown an alarming difference in the impact? Controlling factors such as age, race, COVID has shown alarming differences in the impact across race?
Yes, so I think a lot of are you talking about the cases or are you talking about mortality?
Mortality.
Okay, so as far as mortality goes, we know that having underlying conditions exacerbates the symptoms and the outcomes of COVID-19. So hypertension, diabetes, other cardiovascular issues. So that is what is really propelling the high mortality rate of, COVID. And we see articles of, a 102-year-old lady, she survived. So, however, she did not have any underlying health conditions. So I think, we know that is what's driving the mortality rate.
Okay, and communities of color, specifically Black communities, have a higher incidence of some of these quote comorbidities. Can you talk a little bit about that?
So with the comorbidities, my research relates to physical activity and healthy eating. So all around healthy lifestyle, which will diminish your likelihood of a lot of different illnesses. So I think that, I know that is what's driving it. Like I said, those comorbidities. I speak with Black communities about diet. Giving them alternative recipes for things. So like if you want to cook some greens, some collard greens, can you use smoked turkey instead of pork fat? And they're very resistant, especially in the South, because that's, it's culturally speaking, that's the food that we eat. That's the food that we grew up on and things like that. So it's people do not like the unfamiliar. And that's what is really fostering the resistance.
Okay. Dr. Bell, would you be able to talk about why physician bias is intensely critical during a crisis and during a pandemic?
Yeah, so you're certainly, the bias of a healthcare provider is going to influence the quality of care that an individual is going to receive. So even if you account for sort of the differences in access to care, if you sort of look specifically at quality of care, obviously one of the things that comes into play is not just physician bias, but system bias. So we're saying, that systems or structures, including healthcare structures, are oftentimes set up in such a way to where there is certain populations are disadvantaged. So when you have a situation like this, where a crisis like COVID-19 arises in communities, you're going to have, limited access, certain populations having limited access to care, and then the quality of the care they're receiving is influenced by the biases that are across the board, from leadership all the way down to the implementation of that care.
Dr. Bright, would you also be able to speak to this topic, specifically how we teach against this, or how we can?
Great question. The tough part about this question is I think, as Dr. Bell alluded to, is that there are a lot of institutional aspects of this. I think medicine cannot be extracted from our racist society as a whole, and how our society was founded on white supremacist theories, and how those white supremacist theories are put throughout our whole education platform, which then therefore assigns the value of people's lives and whether or not they receive appropriate care or not. And so from that perspective, I think that one of the aspects of medicine is that we're very traditional. And what we learn most of the time are the actions of those who are in front of us. And so if the persons who we're learning from, our attendings, are showing bias and using stereotypical aspects of how they treat patients, that comes across to us as trainees, and then we assimilate into that system as opposed to speak out against that system. What I'm enjoying now is that my medical students who are coming in now, they're not assimilating. They are calling out us for the way that we have been teaching them stereotypes, for teaching them prejudices. And therefore, I think what we're going to have as we move forward is we're going to have a kind of an enlightenment period, a renaissance, if you will, of how medical education and higher education is going to be performed. Because, we have a traditional white, male, cisgendered view of what is important and what is not important. And so until we start to address that issue, we can't continue to blame people for their outcomes. I heard Dr. Hall talk about the way that we eat. Well, the way we eat was because that was the food that we were given. And we made the best of what we had. That's what our ancestors did. And now that we have a choice, we choose that because it's comfort. And even though we know it's unhealthy, but we know that's where our comfort comes from because that's what we were raised on. But we were raised on that because of the limitations that were put on us by the people that gave us the food. Okay, so we have to understand that we didn't get to this point from an ahistorical perspective. History has a way of predicting where you are in the future and where you are presently because of what has happened in the past. And until we start to define our own history and we decide to start to define our own norms, then we're going to continue to be in these types of situations.
Yes.
And also with the physician bias, I'm sure you all have read the article, I think it maybe came out last month, where Black infants who are hospitalized are more likely to die during that hospitalization if their physician is not Black. So these children, these infants, it's not an access issue. It's not their value, the patient value issue. They're too young to have any at that time. It's all about the care that they received by the physician at that time, and as well as the other healthcare professionals in the hospital setting.
Yes. Dr. Pierce, I'm wondering from a sociology perspective, when Dr. Hall mentioned food and change, if you could talk a little bit about what a food desert is and how that can contribute to some of the health issues that create comorbidities.
Sean, you read my mind. I was about to say that, right? Yeah, let's think about all those structural conditions behind comorbidities and behind disparities, health disparities that then are going to basically be preconditions for potential getting the disease as well as death. So a lot of African American communities, or communities of color in general, are living in places where there's not fresh food around them. So you've got to travel a long way to get to a grocery store, to get to a farmer's market or whatever. And so there are people who are living on, fast food from the gas station or whatever is nearby, right? Or some kind of comfort food. So that's part of the issue, I think, as well as the fact that if we look at access to healthcare, just like we just heard about the example of Black babies dying, there have been so many disconnects between people of color and the healthcare system, so that they're not necessarily getting the kind of healthcare earlier on, for example, in a pregnancy, or in other cases, maybe something was not noticed early enough, diabetes or something that that actually went on longer than it should have because they're not getting the kind of attention from the doctors that maybe white people are getting.
And is there also the issue of socioeconomic status when we're talking about access to food in relation to how much an apple costs versus a bag of chips?
Yes, we could go on and on about all this, right? Socioeconomic variables and cultural variables that are out there that are backgrounds to this, right? And I think that's definitely one. Like, why does it cost more, right, to get fruits and vegetables rather than a burger at McDonald's? And this was something. There's a sociologist at Harvard, David Williams, who spoke at ECU a few years ago, and he has done research on this issue, and he talks about how I think it was Walmart at one point that actually put in lunches for their staff, or maybe the truck drivers, and it used to be very unhealthy lunches, and they suddenly started putting in some healthy lunches and then charging them like less for the healthy lunches than the unhealthy lunches, and so the truck drivers started to eat better, right? So why is it that that fresh food costs more than that food that we can't eat. And it reminds me also of a film about migrant workers here in North Carolina, Latino men who are picking our vegetables and our fruits, right off the vine. And then they have to go shop for their own food in the grocery store, and they can't afford those same fruits and vegetables that they've just picked.
Yeah. That's a great anecdote of how you can kind of see the effects of socioeconomic and racialized systems in place in play in real time of going to the grocery store, honestly, and who can shop at from the Piggly Wiggly to Publix, who utilizes what services based on price. So, Dr. Bright, what would you say are the needs of minoritized communities as COVID-19 affects these specific communities of color?
Well, number one, I'd like to just add on to the last part. When I was growing up, I had a man, his name was Mr. Gearreath. And Mr. Gearreath was kind of a Black entrepreneur who had kind of this business of where he would go to the white grocery stores and he would retrieve the food that they were throwing out, and he would bring it over into the Black community. And what we have found out that's not an abnormal practice, that there are grocery store chains that will take food out of white stores and put them into the Black stores when they get close to their dates of expiration. So we know that these types of things happen. That's not uncommon. Help me understand, we got food deserts, but we have alcohol surpluses. Why is alcohol such a big thing and tobacco so heavily prevalent in communities of color? But yet we can't get any apples. Okay. I think an apple costs less than a bottle of Boone's Farm, don't it? But yet we got more Boone's Farm than we got apples, right? So, we need to look at it from that perspective as well. What is it that they're trying to do? Is this some type of, I was going to use the word genocide, but in many ways we have to question that. Is our value of such that we don't get those things? We got surpluses, what we call food swamps, or bad swamps, where you got a whole bunch of surplus of alcohol and tobacco, but we don't have food. So what do our communities need? Well, we need that to be addressed, number one. And when our communities become gentrified, we don't need to be sent out of our communities into places where we don't have transportation. Our folks need a living wage. Our folks need Medicare expansion. Our folks need the ability to have child care. Our folks need to have the ability to have mental health services to deal with all the post-traumatic slave disorders, this trauma that we have from all of our generations of being traumatized. So, there are a lot of things that our community needs, and that's just the beginning of the list.
Thank you. Dr. Hall?
And to go on with what Dr. Bright is saying, because earlier he spoke about the white supremacist system, and that system is designed to disenfranchise the Black community. So if you were to give us all these pieces that he's saying that we do need, because we do, that whole system will dissolve. So the powers that be have to address that in order for us to be where we need to be and have empowerment for the community, self-sufficiency, not be disenfranchised like we have been doing. So in order for that to take place, the entire system has to be revamped.
Right. We have to get rid of redlining, such that our communities of color actually have the ability to have a valuation of their houses, such that they're able to accumulate wealth. We all know that the average wealth of a Black family is only 10% of that of a white family. We know that during the Great Recession, that an average white family had a value of $130,000. An average Black family had a value of about $12,000. By the end of that recession, the average white family had a value of $121,000. The average Black family had a valuation of $1,200.
Oh, wow.
So if economically we are so disenfranchised, and the number one reason is because of housing. Then let's go to public school and public education. Well, how do we make the funding for our public school systems? It's from the tax bases. How are tax bases formulated? From our communities. What are our communities? Segregated. So if you segregate all of the low income people in one area and use that tax base for that public school, how do you expect? That's exactly how a rose grows out of the concrete, right?
Mm-hmm.
That's the reason why he has to grow out of the concrete, because there's no ground. That ground is your wealth. If you have no wealth, you can't have a ground. You're starting off on top of it, on top of concrete, trying to grow.
And this goes back to your first question, Sean, on, why communities of color, they're not being tested at the same rate. They have the medical mistrust, and that's going now to the clinical trials for the vaccines. If you have been disenfranchised in all these different areas of your life, why would you participate when it comes to, medical research?
Yeah. Dr. Pierce, can you talk a little bit about what redlining is? Dr. Bright brought that up, but for those that may not know, can you talk about what it is and how it got started?
Sure. And I just want to add one thing before I do that, which is to let's think about how COVID is going to also become a variable that is going to exacerbate what we're talking about, right? Because evictions are now starting. Housing, as we mentioned, is really critical. So, what's going to happen when we have a growing homeless population, a growing population that's transient, that's lost money because they've lost jobs. So I think we're just kind of at the beginning of seeing a potential disaster, unfortunately. So redlining is it's a practice that still goes on informally, but it actually was formally and legally used back in the middle of the 20th century to segregate neighborhoods. So it meant that banks would not would not give a mortgage to people who bought in a particular neighborhood. And so it kept housing values down in Black neighborhoods, right? And they were able to be steady and increase in white neighborhoods. And because of that history, those lines are still there. Those neighborhoods are still segregated, right? But it's also going on informally. I think there's still discrimination against people of color in terms of buying houses.
There was a recent example of this in Florida. There was a couple, one, I think it was the man was African-American, the woman was white, and they had a child, and they were getting ready to sell their home, and they had an appraiser come in, and the appraised price that came back was much lower than they had anticipated. So what they ended up doing is they removed all the family photos in the house and had another appraiser come in, and it came back at a much higher value. Wow. And so that's kind of the informal, so redlining or discrimination that occurs in the housing market.
Yeah, that's definitely a recent example. So a question from our audience is, how can we as future healthcare providers, public health workers, ensure that we are establishing an anti-racist healthcare system as individuals? And I'm going to look at Dr. Bright or Dr. Bell to answer that.
Well, it first starts with you. You have to examine yourself and understand where you are coming from. I've been reading the book by Kendi that talks about Stamped, and it talks about 3 different camps of people. There are segregationists, there are assimilationists, and then there are anti-racists. And sometimes you have to examine yourself to figure out what part are you, because we're not all perfect. Well, none of us are perfect. Let me start there. But we all have our flaws and we all have our opinions, and all of us are impacted by the deep-seatedness of racism. And so we have to be cautious ourselves to think about when we make decisions, where did those decisions come from? What basis am I making these decisions on? Are these decisions that I'm making coming from a place of fairness, or are they coming from a place of privilege? We have to understand and examine our own privilege and how we utilize that for the help or to not help others. And so from that perspective, and then, like I said earlier, we have to question what we're being taught, what perspective we're being taught it from, and then are there alternative views that we need to be looking at that we haven't looked at before because they were not part of the norm as it relates to what is being taught.
Yes. So I do want to take a second to welcome our other panelist. She was able to join us, Kelly Smith, who sits on the Pitt County Board of Health. Am I getting that right, Kelly? Hi. So I'm going to direct this next question at you. Thank you for joining us. In what ways does our local officials around public health impact some of those systems in place of how we're collecting that data that informs the study of these diseases?
Well, certainly our health department is equipped from an expertise perspective to be able to collect data however we want and need to. The challenge is not the expertise at the health department level. The challenge is accessing the data by being able to access the population that we need to get that information from. So having access to that information, willingness to provide that information to a health official. I heard the other panelists talk about the mistrust and the distrust in our healthcare community with our population, and so that's part of it. And so they are certainly, the expertise exists. It's a matter of being able to get your hands on that information. And it's also the willingness of the higher level officials to guide and direct our other healthcare constituencies to make it a priority. Because we know that as a health department, they operate at the will of our county commissioners and the will of other political bodies, and so the priorities that are their priorities are truly guided and directed sometimes by other folks.
Yeah, that kind of leads into my next question. And I think that's a really great point, is the looking at our governmental leadership, whether it's our local officials, such as our mayor, our governor, and how, or even the president, and how they've been handling these issues. What is the true impact that our government has with these mandates on how we handle this virus? Because we've seen that even with gyms closed and with some of these expectations, we've still seen issues around the disease still being spread, of people not necessarily following the precautions that have been shared. So in what way does government play a role? And is that limited? And if so, how much so?
So of course the government plays a role. I mean, I don't know that there's an aspect of our lives that our government does not have a role, whether it's an active role or a passive role, there's a role there, right? So, in dealing with this pandemic, we have a government that can either choose to funnel the resources to those populations where they are most adversely impacted, or they can choose not to. And they can choose to prioritize certain behaviors. Sometimes that means mandates for things like wearing masks. And sometimes it's a matter of, don't tread on my rights, and don't command me to do something because I don't want to do it. It invades my personal space. And so our government certainly has a role in that, in where they choose to fall on that. It really is the whim of those folks that are in those positions, right? And the people that are buoying them up. So, if we can just go ahead and put a plug in, this is a reason why it's important for us all to vote, right? Because whether you vote or not, you voted. And so you have to choose who you want in those governmental positions to help guide and direct how we do what we do. Because this might be the first pandemic in this scale that we have lived through, but it won't be the last. And so what are we going to do the next time that thing happens?
Yes. So in looking at that, and looking at who our public health leadership is, even locally or nationally, why do you think that it's important, or why do you think we lack such a strong minoritized or marginalized voices when it comes to public health leadership? And this is for you or Dr. Bell. Dr. Bell, would you be willing to answer?
Well, yeah, I mean, I think certainly as you think about the people who are in positions of leadership, the vast majority are not people of color. So that creates a disadvantage. And oftentimes those systems that have been established, the sort of the healthcare, public health infrastructure are oftentimes structured in such a way to prioritize certain populations. And so to when we get to that point where there's more diversity in leadership, there's more diversity in access to those resources that are needed for a strong public health and healthcare infrastructure. That's the challenge we're going to continue to have.
Dr. Bright, how does this show up within the hospitals? As far as having administrators and folks making policy that are coming from these most impacted communities?
We'd have to change the whole power, how do we determine the policy, the committees, and all of the structures that we have in place to have people become a part of that. That's why I kind of like the model from the federally qualified health centers, in which their boards have 51% of those that actually utilize the facility to make up the board. That's an example of a way in which our community members and those who are at risk and the highest skin in the game can be a part of the decision-making process. But even then, you have to have the right people in there that have the ability to A, feel confident in speaking to leadership, B, being able to confront with facts as opposed to always confronting with emotion. And they have to have the ability to be able to perform the appropriate research and be able to read the information to the level that is needed in order to understand what the impact of different moves within a service or hospital mean. And even sometimes us as physicians may have all this knowledge about being a doctor, but we don't even understand how we're contributing to public policies that impact people of color even more. Like, for instance, we develop protocols about how to take care of MIs, but we never develop a protocol to how to help get rid of the inherent bias of the physician as the person is coming through the door to make a determination whether it's an MI first or whether it's heartburn. And we treat them first as heartburn until like 20, 30 minutes later, they start to have the blood pressure drop. And then we go, oh, no, it's not heartburn. It's really a cardiac event. Well, we've lost 20 minutes of time. And that's important because with heart attacks, time is tissue. So if we're not getting somebody into the cath lab very quickly, or same thing with a stroke, so these are the types of things where even when we would say that we're doing things equitable, until we actually disaggregate the data, we really don't even know that. So that's where data comes into play.
MI is myocardial infarction, a heart attack?
I'm so sorry. Yes, ma'am.
Okay.
I went jargonistic on you.
Dr. Pierce, you had a question for Ms. Smith.
I do. Yeah, I have a question for Dr. Smith. But first, I just wanted to say that in response to the question about, public leadership, right, is that I think we're all aware of just how much fracturing is going on between certain levels of leadership where they're not in agreement, right? National versus local versus state, and the way that our society right now is so polarized over the issues of how to deal with this, and that puts the public, I think, at risk. But Dr. Smith, I had a question because one thing that's come up this week is the outbreaks in our Greek system here at ECU, the clusters, and I know I heard an interview with someone on NPR who said that that actually it's the nationals that have to close down those houses, that universities don't have control over what to do with those living situations. But someone brought it to my attention that our local health department could actually close down those residents' houses, and I just wondered what if that's true.
I wouldn't be able to answer that. I have no clue whether or not and it's the health department and the health director, not the Board of Health, that would make that call.
Okay.
I don't know if the health director has the power to close down a residence. What I do know, and I work very closely with the rest of the board, and what I do know is that our current health director, Dr. Silvernail, is incredible about providing very non-biased data to the folks who really can make those decisions far quicker and less heavy-handed. And so this goes back to whether or not, from a leadership perspective, people are willing to take that information, what they do with it. But I can't answer that with any certainty as to whether or not he has the power to shut down the campus or not. I'm sorry.
Okay, that's all right. Thanks.
Yes, to Dr. Pierce's point, ECU, from my understanding and having worked in not worked in Greek systems, but in conjoining with Greek systems and housing, we don't own those houses, so we can't tell folks that they have to close them down. They work in collaboration with, but they're owned privately. So yeah. So in thinking about all of this and thinking about how information has been spread, misinformation has been spread in relation to the virus, what do you think is the role of the media in providing accurate information? And how do we, as consumers of the media, weed out what is the most accurate information for how we take care of ourselves?
So I would, just personally speaking, so I have not had cable or satellite in over a year. And I, personally speaking, am very disillusioned with the media. It's the same talking points regurgitated. Depending on what station you listen to, you might get a different spin. However, it's the same frame. So I know a lot of people in my network, they do not believe what the media is telling them. They want to experience things for themselves. And as you see, we've had people, especially young people, and they're like, no, I'm not going to socially distance. I am going to have the get-togethers at my home. And as a result, they have a positive case of COVID. So maybe if we take out the media's responsibility and look at it maybe from a local level, it might be more effective, but that's just my take on it.
Okay. Dr. Bell or Dr. Bright?
Yeah, I mean, I would, under normal circumstances, say that, our most trusted resources are, local, state, federal agencies that, generally have our best interest in place. It's unfortunately become a very political process. And so I think that we are, in a situation where we just have to be just very discerning. And social media plays such a huge role in all of this. People will, retweet, or they'll share a YouTube video and just, say that, this is fact, or this is driving their opinions on things. And it makes it really difficult in this current climate to make sure that accurate information is getting out there, and it's not politicized, or it's not, something that's slanted a certain way.
Yeah, I agree with that. It's kind of, you have to be able to do your own research and understand that every story has a motivation behind it. And try to understand the writers or the reporters' perspective and the slant that they're coming from, because everything is so politicized now. But you know what I find interesting is those sometimes you come out with these stories like one I just read today, where it talked about of all of the continents that are having issues with COVID, Africa is the one continent that is not. And the question becomes, so wait a minute. So in America, is Black folks who are dying from COVID, but yet those same type of conditions are occurring over in countries in Africa, and they're not having the same type of outcomes. So what's the difference? And now that they're going to research that to try to figure out if there's something that has to do with the vaccination rate over there for swine flu or something like that, that may have given them some type of immunity. But it's we would have expected, or we would have hypothesized that Africa would have been decimated by this because of how the media depicts the continent of Africa and the nations that are there. But yet they're the ones that have a much better public health service system than we do in this modernized country, over this modernized United States.
Ms. Smith, how would you say that the department, the Board of Public Health utilizes the media in getting out the messages?
So Dr. Silvernail, if I remember correctly, he was doing regular conferences, media conferences, where he would share the information as it pertained to Pitt County. And keeping in mind, we're just talking Pitt County for this, even though Eastern North Carolina is, 29, 30 counties. And so sharing that information and trying to stay in sync with federal agencies like CDC to keep a consistent message, so that there's little confusion, although that is left up to debate, right? Because your federal agencies are not on the same page. But that is what he has used. The other thing I will say is that they do have a group of employees, staff who go out into the community. They're doing testing in the community, so they're sharing information when they have that one-on-one time with community members and educating in that way. And so every time they have someone coming into the health department, that's an opportunity to educate and to share. And so really from a public health department, a lot of what they do is very grassroots. Okay. Because we're rural and so small and oftentimes incredibly underfunded and incredibly understaffed. And so what they have at their disposal is that one-on-one, is that, when there's someone coming in to receive primary care, using that as an educational touch point for them.
Okay. Dr. Pierce?
Yes, thank you. I want to follow up about Africa and also about the media. I believe I read a report about possibly Kenya having just a really great public response to this. In other words, that they were able to control it somehow through, the way the government reacted to it early. But don't quote me, I'll have to look that one up. But regarding the media, I think so much, especially because of social media, right? So much information that people think is knowledge are these sound bites, right? Because we've often short attention spans. So it was what came over your news feed, over 2 seconds is what we're believing. And I'm somebody, I don't have cable, and I'm an NPR addict, for better or for worse. But I feel like NPR is a place where you can hear on some of these programs, some of these extended discussions like the ones we're having now with actual, public health experts and, and social scientists that I think help us to get to this nitty gritty. And I think that's the type of thing we need to pay more attention to than, whatever came over your newsfeed today.
Yes. So in talking about media and how it's contributed for better or for worse in our perceptions around COVID-19, and looking at how officials have talked about and specifically speaking about government officials in the federal government have spoken about this virus. Do you think that that has contributed to the xenophobia that we're seeing as far as the uptick, not only just in xenophobia, but also in the lack of care for from fellow Americans to each other? Because at least for me, I saw at the initial onset of this virus, when we thought that it affected everybody equally, there was a larger sense of community care. And then when it was publicized that it affected communities of color much more, the care level kind of went down. And that's when we saw some of those protests, like in my home state of Michigan, where they showed up to the state capitol with armed weapons. Do you think that all of this has contributed to that? And how do we create that sense of care with one another, similar to some of our Asian countries where wearing a mask is a part of their everyday practice of practicing care for others? And I know that was a very wide question, but Dr. Pearson, Dr. Bright, go ahead. I'm sorry.
I was going to say, but that's not our culture. Our culture is rugged individualism.
Mm-hmm.
That's what America was founded on. And so, when we talked earlier about the aspect of wearing a mask and we talked about individual freedoms, well, your individual freedom ends when you start impacting me. And by you not wearing a mask, you're impacting me when I'm wearing one, right?
Mm-hmm.
But that's kind of been some of the arguments behind why folks don't want to wear a mask, is because we're rugged individualists. And the thing is that you talked, I don't know if it was here, we talked about otherism, where we get marked. We talked about the book, the stamped. Well, this aspect of markedness and how as anything other than those rugged individuals get stamped as others, and that's called markedness. And then we are then saw as a group instead of as individuals. And so all of that comes into play. I'm rambling. I'm sorry. Forgive me. But I think that's part of the issue is we have individualism is more important than the collective.
So then the question is, how do we change that?
Right. I totally agree. And I think that, and it's interesting watching these protests, how the First Amendment, protected, so to speak, like I don't have to mask, along with the Second Amendment. So I get to, I need to be here with my guns and express my right to not wear a mask, right? And it gets very dangerous at that level. And I agree. I even though correlation isn't causation, I think we did notice that once we saw how the morbidity rates were higher in people of color, that this anti-mask sort of element started to become a lot more visible, right? And coming into the streets. And I was fascinated that to learn that in Japan, they have been masking since the 1918 pandemic. I mean,
Oh, wow.
It's fascinating to me, right? Something that I can't imagine us doing here, but I wish we would.
And I know in China specifically, I was in Shanghai, they wear the mask as well because of the smog.
Mm.
It's very thick. It's very thick. It's very visible. But I was going to say, Sean, that first time that we saw that lack of care of your neighbor is when COVID-19 was just affecting the elderly. So then younger age groups, oh, well, I'm fine. Then we had the data that 80% of those with the virus do not have symptoms. So people really felt like, well, I'll just get it and, it's not going to affect me adversely. And so there's been a lot of levels of that has diminished care for your neighbor and their well-being.
Definitely.
Sean, if I can jump in real quick, you know what
Yes.
comes to mind for me is I'm a child of the 80s, so I remember the AIDS epidemic. And so this is it just almost on the reverse end. When it first started out, it was gay men, and it didn't get much press. It didn't get a lot of attention. It didn't get a lot of funding for research or treatment. And then as it started to eventually affect more people than just this one group of folks, then all of a sudden there's all kinds of research and money. And then it ultimately ended up where it was affecting so many Black and brown folks, where there was a lot of research. Now we've kind of come a little full circle with that because it's global. But we saw that some even with the AIDS epidemic. When it first started out, because it was a marginalized community, nobody wanted to talk about it, nobody wanted to touch it, nobody wanted to treat it. That's their problem until it became everybody's problem.
Mm-hmm.
So I think Dr. Bright was absolutely right. It's about rugged individualism, and it's until it affects me, it doesn't matter.
Mm-hmm.
And Dr. Smith, we see that right now with the opioid crisis compared to the crack epidemic. You're going to get locked up. There is no treatment. Now there is treatment and you're not prosecuted. You have no criminal record. And that is because it has affected the politicians' children and their other relatives. So it hit home for them. So the response has been different.
Dr. Bright is cheering you on.
Well, what you just reminded me of is the aspect of proximity. That the closer you are to an issue, the more likely you are to advocate for it. And so until it knocks on your door and says, hello, problem here, you don't really have anything to why you want to sign on for that. Until it impacts somebody that I mean, most people are indifferent about rights for gays and for same-sex marriages until it impacted their family, that somebody in their family came out as being gay. And then all of a sudden now, they had to go through that process. Oh, I don't understand. I can't believe it. And then they came to understand that person and know that they love that person. And so they get to know more about that issue. But it wasn't until it became proximate that it actually had a meaning to them. And that's the word I've been looking for all morning, was proximate.
Yeah, that's very true. So yes, Dr. Pierce.
Well, I just to add to that, you're totally right, and I think that the fact, I'm going to defer to the medical professionals here. I hear that that COVID has already mutated hundreds, if not thousands, of times, right? So, how do we know whether those new mutations, might actually affect a more general population, right? That don't have these underlying conditions. Like, how do we really know?
Well, but that's one of the things is they're hypothesizing that there are many different types of coronaviruses, and that some of those coronaviruses may have produced common cold-like symptoms that may have already gone through populations, and they think that may have happened in countries in Africa, and that's why we're not seeing the same type of outbreak over there that we're seeing here in America. And we do know that coronavirus does mutate because the strain that affected the East Coast, there's not the same strain that affect the West Coast. And that's because of where people came from that brought the virus in. And so certainly this is going to be an issue. And this is why vaccines are so hard to manufacture, much less ones that are going to confer immunity for a long period of time, because viruses mutate. And we need to understand that as a public. And that's why we practice medicine, because we are perfect.
And we're in such a rush to not allow the science to evolve. It's, one study comes out and everybody jumps on that bandwagon, and then another study comes out that contradicts that study, and they're like, oh, well, who are we to believe? And it's just, that's not science work. I mean, science is a body of information that you collect, and we're only 6 months into this. I mean, it's not like, and that's from a scientific standpoint, that's a relatively short period of time. So the fact that somehow we're talking about having a vaccine to distribute by the end of next month is crazy. So that's but that's where we're at. It's just that people are so, frustrated that they want to be done with this. They don't want to think collectively, and so it's we're pushing things along, and that's going to cause some problems.
That leads right into my next and last question. What does this vaccine look like? And then how are communities of color going to feel comfortable utilizing this vaccine when kind of how the process has undergone? A lot of folks don't know because normally a normal vaccine, from my understanding as a layman, takes years because it has to go through animal testing, different drug approval stages. So what is this going to look like, as Dr. Bell mentioned, if we're rushing to get this out there?
Well, I mean, so there is the, the Operation Warp Speed where they, are trying as best as they can to put systems in place to where there's, mass distribution and processes in place where people can get the vaccine. Obviously the concern is that, are you going to mandate this? So are you going to require people to get a vaccine? That's going to cause a challenge. You're gonna have people that have negative side effects to this. What are the implications of that? So it's gonna be, and then, we haven't even discussed how we're getting ready to go into flu season. And so, flu and COVID on top of each other is just going to be, it's going to be a hot mess. So that, that's kind of where we're at. I mean, I think we're in a situation where, there's going to be a lot of people who don't want to do this. And if they're if we can't get people to wear masks, what's the likelihood that they're going to take, a vaccine from the government that really hasn't gone through the months and months of rigorous testing that it really needs? There's a lot of people that aren't going to do it.
Well, years of rigorous testing.
Yes.
Yeah, here's the issue for me is, what am I going to say to my patients?
Mm-hmm.
That's what I've got to figure out. Because if I'm not taking my family and I'm not getting it myself, am I going to tell my patients that they need to get something that I'm not willing to get myself? And that's part of where we have to understand what is our moral compass as it relates to this as a society, and then B, as individuals.
Yeah, I definitely think that that's true. And now I'll speak for myself. Given the history of medicine and its experimentation on Black communities, and the fact that they were even talking about doing the vaccine, testing it in Africa first, I don't trust the current systems and folks in charge with this vaccine and me taking it. Henrietta Lacks, the syphilis experiment, how the founding of gynecology, all of that in and of itself does not lead to trustworthiness when we're talking about this. But
I understand your perspective, but understand this: it ain't gonna be just communities of color. It's gonna be everybody.
This is
Everybody's
true.
going. There's a phase 1 trial, phase 2 trial, phase 3, right? Then it's released to the public. That's called the phase 4 trial. Okay, and what we're going to have is, because all the way up until that point, it's been controlled. But once it gets out to the public, everything is wide open. And so all the people who were not part of the study because they had pre-existing conditions or because they were on other medications, now they're going to be part of the equation because they didn't test for that. That's why I call it a phase 4 trial, because you don't know how the drug is going to really react until it gets out into the public. And you stop having these controlled trials that you have these clean patients that have no medical issues. Okay, so that's why it's going to be an experimentation on all of us, not just people of color. Everybody that takes that shot is going to be part of this big experiment.
And will it result in mayhem? Because as you said, Sean, in Michigan, they raided the state building, over masks? So
Yeah,
now they want them to inject themselves with something. So how will the public react?
Yes.
Yeah, and I had the same question. What about these anti-vaxxers that have been anti-vaccine now for years? Are they going to come around or not? And if they don't, right, is that going to put everyone at risk?
Well, this is a interesting place to leave this conversation, but as I promised, we were gonna end at 60 minutes. So I want to thank all of our panelists for your time and your expertise. The ultimate goal for Diversity Dialogue Series is to create space for open communication regarding the issues that affect us all. For with understanding, we can work together to dismantle the problems that consistently plague our society. Please keep talking, questioning, and listening to one another, for that is the only way to continue to drive social change. Our next Diversity Dialogue Series will be October 19th, where we will discuss anti-Blackness in non-Black communities of color. So I hope to see you then. As always, stay happy, stay healthy, and stay safe. Thank you.
Thank you.
Thank you very
for
much.
having us. Y'all stay safe out there.
Thank you.
You too.